Good morning, everyone. I'm Dr. Bhavya. I'll be presenting a work on redefining ocular pain in with confocal and molecular signatures. There are no financial disclosures. So, when we look at the patient profile that walk into our clinics, there are those who do not complain of any ocular surface discomfort and they do not have any clinical signs of dry eye disease as well. And there are those who don't actively complain of ocular surface pain, but when we examine them, we may see some signs of dry eye disease in them. And then those who actively complain of ocular surface pain, discomfort, and their signs correlate with the severity of the symptoms, and we can treat them easily with the conventional dry eye disease management. But then comes our most troubling cohort, are those who have very high ocular surface discomfort or a chronic refractory symptoms, but when we examine them, we may not find the clinical signs that correlate with the severity of the symptoms. So then we wanted to understand what are the pathomechanisms behind this troubling ocular surface pain in these patients. And with this knowledge, we wanted to develop an algorithmic approach to manage them. So what we thought was the relevant mechanisms, pathomechanisms behind this ocular surface pain was ocular surface inflammation, which we tried to study through the corneal dendritic cell density with confocal microscopy and tear-soluble inflammatory cytokines, as well as dysregulated ocular surface nociception, again by analyzing the tear-soluble nociceptive factors, and then looking at the neuropathic component through the presence or absence of microneuromas through confocal imaging. So we tried to establish a novel algorithmic approach in management of patients with ocular surface pain. We considered clinical factors like OSDI score and tear film instability, as well as confocal microscopy features and tear-soluble factors. So this is our novel classification system, which I have described earlier, which we call discomfort concordance staging, where we give emphasis to the discordance between the patient's signs and symptoms and the chronicity, the refractoriness of the symptoms, whether these symptoms correlate well enough with the clinical signs the clinician can examine on the slit lamp. So we included patients with primary symptom of ocular surface pain or discomfort. Our controls did not have any clinically delineable signs of dry eye disease, or neither did they have symptoms. We excluded patients with aqueous deficiency dry eye and other confounding variables. So we did a tear collection and soluble factor profiling with our in-house molecular lab. And we also collected the clinical factors, including ocular surface disease index, as well as tear film stability was measured through tear breakup time testing. The confocal microscopy gives excellent cross-sectional images of all the layers of the cornea. So on confocal microscopy, we studied the dendritic cell density, both mature and immature, the subbasal nerve plexus features, as well as presence or absence of microneuromas. So what we found was interesting. There was an increase in corneal dendritic cell density with the increasing OSDI score. Similarly, in those fourth subset of patients who had discordance between their signs and symptoms, actually had higher dendritic cell density compared to the other groups. In these patients, a higher proportion of these patients with discordance of their signs and symptoms had microneuromas compared to the other groups of patients. And another interesting finding in our study is when we assessed their tear factors, there was a imbalance between the pro-nociceptive factors as well as the anti-nociceptive factors. These patients had dysregulated nociception and they had higher pro-nociceptive factors like interleukin-17A. So we believe that we could give the answers to this troubling question, like why does my patient has this ocular surface pain? And they may be having higher corneal dendritic cell density, higher microneuromas, and altered ocular surface nociception. And we brought out these results in a single cohort, and we tested the tear molecular factors, the confocal microscopy, and the clinical factors in a single cohort. What we know is all these features were previously studied, but they were studied in different cohorts, and we brought them all in one subject cohort, and we also tried to give a molecular target for future therapies, which is interleukin-17A. And we also gave a novel algorithmic approach where we show you that if you find a discordance between the clinical signs of dry eye disease and ocular dry eye disease and the patient's symptoms, try to look beyond the traditional tests of dry eye disease, look for subclinical ocular surface inflammation through confocal microscopy, think there might be some level of dysregulated ocular surface nociception, and also look for, think of neuropathic pain component. Maybe it is better to involve a neurologist in your treatment paradigm. And and in future, we are looking for possible targeted therapies for these patients. Together, we can help these patients in a better way than with the existing management plan. So this is our first ophthalmic lab on chip, which we are trying to include in our day-to-day practice, which also helps in the TR molecular factor analysis in the future. Thank you.
Thank you.
So you mean to say that people who are having symptoms with no signs, they really are in trouble?
Yes, sir. Even though we may not be able to see them through a traditional dry eye test, they may be having some subclinical inflammation, which is better delineable with confocal microscopy features, and also the tear-soluble factors. That's the reason why I included the last slide. So we don't have it available right now. We cannot test for altered nociception, which we keep talking about. Like these patients may be having altered nociception, their nociceptive pathways may be different from the other dry eye patients, but these are all conjectures. So we are trying to bring that out. I showed you interleukin 17A, but there are other nociceptive factors as well. So if we can study them in our clinics, or not for all patients, only those selected subset of patients with chronic ocular surface pain, which we are not able to treat them effectively, maybe we can bring out.
Yeah, so any recommendations for their management?
Sir, one is if you find microneuromas in these patients, think of neuropathic pain. As I told, involve a neurologist and use tricyclic antidepressants in these patients, apart from the regular dry eye management. And also autologous serum may be helpful in these patients because it has anti-nociceptive factors and anti-inflammatory factors as well, but only in selective patients.
Are these microneuromas the reason for the pain, or are they a consequence of the inflammatory process?
Yes, sir. So that is, we cannot decisively establish it because it is a vicious cycle. So when there is an ocular surface inflammation, which is evident with increased dendritic cells and all, that changes the nerve, that inflammation, the nerves actually respond to that inflammation through the formation of these microneuromas. Or there could be a primary neuropathic component as well, without a coexisting ocular surface inflammation also. So it could be both cause and effects.
There is the MMP9 strip already available. Does that correlate with any of this work?
Yes. We have other work parallel going on with the kit we have shown you. We are testing 8 analytes. Okay. So right now we haven't done a correlation between that, but we also have an MMP9 in our kit as well. Okay. So we are looking
at that's easily available. Does that help us in any way?
Yes, ma'am. We have to establish, yes, MMP9 that kit has been established for dry eye disease management, yes, I'm aware of that, but it's not just the MMP9. MMP9 is a pro-inflammatory factor, but it also helps in wound repairing as well. It is a matrix medulloperineus. So we are also looking at other pro-inflammatory factors. If you see the slide, we have interleukin 1, interleukin 6. These are more important primary pro-inflammatory factors. So they may be having more important role in dry eye disease than MMP9. We don't know unless we look for it.
Okay. Thank you.